Good evening, everybody. Thank you all for joining in. It's a pleasure to have an esteemed panel, Dr. Ravindra Mehta, who heads the Pulmonary and Critical Care Division at Apollo Hospital, Janagar. He's a man who doesn't need much introduction. And I'm also joined by Dr. Guru Prasad from Chirayu Critical Care at Gadag. He's a good friend, and I should say is an expert who has actually done a lot of good work in the northern parts of Karnataka. Both are extremely great academicians and clinicians, so it's an honor to be moderating this discussion. I'd also like to thank ACME and Fisher and Paykel for giving us this opportunity. So without wasting much time, as you all know, the topic will be on HFNC in COVID. So HFNC itself has come a long way, and I think it's found a new niche in the treatment of or in the management of respiratory failure due to COVID-19. Despite its extensive use and the fact that we know so much about it, I think there is a lot of gray zones and a lot of theoretical sort of dilemmas that we face, and how do we deal with these things, and also how do we try to approach and apply this clinical tool in our day-to-day practice in this COVID-19 era is what I would, what we would like to discuss. Okay, right. So anyway, I think let us start off. Dr. Guru Prasad will spend the first few minutes on a brief outline on what is about HFNC in COVID-19, and then we will open the house for discussion. Guru, the stage is yours.
Thank you, Sunil, for a nice introduction. Hello, Dr. Ravindra sir. At the outset, I would like to thank ACME and Paykel for giving me this opportunity. I hope my slides are visible.
Yes, yes.
Okay. So we'll start off the topic. That is heated, humidified, high flow nasal cannula in management of COVID-19. It's actually an heated topic, high flow nasal cannula in COVID-19. Very few knew about high flow before COVID, but now everybody talks about only high flow nasal cannula in the treatment of COVID. So what I will cover in the next 30 minutes is to just give a brief introduction what exactly HFNO is, how does it work, and how do you set a HFNO, advantages of HNO over low flow devices, and the role of HFNO in COVID-19 patients. Okay. We are very familiar with these oxygen delivery system like a low flow nasal cannula, a simple face mask, venturi mask, and a reservoir mask. And there is a certain amount of flows which we can give in each system. Giving more than 6 liters on a flow nasal cannula doesn't help. It will go a waste. And now oxygen being a very important resources, we have to try to save oxygen for the next 3-4 months, because getting oxygen has also become very difficult. So your use of oxygen should be very, very careful. And that actually, when you titrate HFNO's machines, you have to be very careful. Just try to keep a saturation about 90, more than enough. Okay, and these are the various flows where these oxygen delivery devices can give, and this is the maximum saturation. So if you are using an oxygen NRB with reservoir bag, you can go up to 60. But only thing is it's variable. I'll tell how it actually happens. So what are the advantages of low variable devices? It does not deliver a reliable FiO2, which is very, very important in this scenario. It is poorly tolerated for prolonged use. Flows higher than 15 liters per minute of dry may be injurious to the airway mucosa, and higher flows can be inadequately warmed, and humidification may not be that adequate. So HFNO is nothing but high flow nasal oxygen. It can be also called as high flow nasal cannula. It needs a special device to deliver a high flow. Gas delivered are heated and humidified, and it has got each company has got its own machine and a compatible circuit and an interface. So there are few parameters on a machine which has to be set, that is the temperature, the flow rate, and the FiO2. So what are the problems if there is reduced humidification, which is naturally, actually physiologically, the inspired air should be humidified. So an reduced humidified oxygen causes drying of secretions. It uses which leads to reduction of the ciliary. In fact, it prevents this of the airway epithelium because it becomes dry. The mucosal flow also gets hampered. The drying of mucosa causes plugging of small airway, leading to small airway obstruction, which in turn leads to atelectasis and natural arterial desaturation. So humidification, there are two types of one which we usually see with low flows, where humidifier bottle and then comes to the tubing. That is a nebulized way of humidification, and what we HFNOs is an active humidification. The difference is the nebulized water, the nebulized water droplet is about 1 to 40 microns in C, a virus or bacteria with it. But a water vapor that is generated with an heated humidifier is of a size of 0.0001 microns, which is much smaller or a bacteria. So when oxygen which is carried with this water vapor doesn't carry a virus and bacteria, and the chances of infection is very minimal. So what is the physiological basis for the use of HFNC? Normally when we breathe, we generate a gas flow of about 15 liters per minute. The air is warmed and humidified in the upper airway. Gases reach temperature up to 36 degrees centigrade and humidification about 80 to 90%. But if the patient is in distress and breathing through the mouth, this maximum relative humidity comes down to 70%. If a person exercises or is in respiratory distress, flow rates may reach up to 120 liters per minute. But when such flow rates are achieved, but it can be achieved only for a short period of time because the person becomes fatigued. So this leads to a increased fluid loss, which we call as a third space loss, and we need to have higher oxygen requirement to achieve a warmed gas. This is a diagram which will explain to you how different and high flow nasal oxygen device is. If on a variable or a low flow device you use up to 10 liters, you may get an somewhat good FiO2 will be delivered to the alveoli. But if the patient is breathing heavily and is generating huge volumes of air up to 30-35, the FiO2 which is set and what is delivered, there will definitely be a mismatch because of the high flows. This part is taken care by the high flow nasal system, where by setting higher flows in the machines, the set F and the delivered FiO2 will be near matching. So this is what we have to focus on, that is an variable or a low flow device will not deliver the set FiO2. So what does a human air helps is, it a natural balance of heat and humidity in healthy lungs. It enables the comfortable delivery of high flows, and it improves the mucociliary clearance. Said that if with these high flows and if the keeps his mouth closed, a certain amount of pressure develops in the airway, which is called as a dynamic positive airway pressure, which indirectly improves the functional residual capacity. So breath and flow dependent airway pressures are seen. It promotes in slow and deep breathing, improves alveolar ventilation. This cartoon shows this is a normal breathing which is happening. So this blue part is inspiration and this is expiration. And when high flows are given through the nasal machines, this is the flows that are raised. So this will, the airway pressure proportionally increases with the increase in the flow. So it creates a sort of peep. The same is depicted in this figure, where On the x-axis is the flow, which is liters per minute, and it is in the as the flow keeps on increasing, so the pressure keeps on increasing. So it is said that every 10 liters of an HFNO machine increases the PEEP by 1 centimeter of water. So a maximum of centimeter PEEP can be applied when you set flow at 60 liters. It reduces the cardiac preload by increasing the intrathoracic pressure, and it seems to alveolar recruitment, which leads functional residual capacity. The next important is it decreases the dead space. Most of our expired air space is in the naso and the nasopharyngeal area, as shown in this figure. What an high flow oxygenation does is it clears the expired air in the upper airway. It reduces the rebreathing of gas with high CO2 oxygen, thus leading to increased ventilation, and which is very well demonstrates clearance of the radioactive krypton tracer from an upper airway model, which is superimposed with a CT scan model. What you see is here is a non-breathing person where the dead space is about what we say is 150 ml. The volume of 500 ml is taken. Almost 150 is remains in the dead space. But as the nasal high flow keeps on increasing from 15 liters to 45 liters, so this is a minimal amount of dead space that is left over with an high flow cannula, which is again depicted in this graph. The flows keep on increasing, dead space decreases. So how does an HFNO helps in a patient's improving comfort? So you get an optimally humidified inspired gas. It is an open system. So what a patient faces with an NIV mask or an helmet mask is not there. So, and it doesn't need an absolute seal. It allows the patient to cough and take his feet. More important, he can communicate very freely with us as well as the relatives. The scenarios in ICUs has changed in these COVID days. Initially, nothing was allowed in an ICU. Patient had to walk in. They never used to walk in also. They used to be trolleyed in. But here the patient is given a mobile phone so that he can communicate with his family. So definitely a mode like HFNO is going to help in better communication, and definitely the risk of bacteremia or pneumonia is decreased in HFNO. So what are the clinical indications of high flow nasal oxygen therapy? Is the most important is an acute hypoxic respiratory failure. It can be used in post-extubation phase in the ICU, in post-operative period, post-extubation can be used. During pre and peri period of the, it helps in pre and peri oxygenation during intubation. Now, especially in this COVID era where you are intubating a patient whose saturations drop so low, this high flow nasal oxygen tries to maintain a better PaO2, and it gives you buying time if at all the intubation is delayed or whatever. So HFNO is there is a definite use in pre and peri oxygenating during intubation. During bronchoscopy for apneic ventilation, HFNO is used. It is used in respiratory failure and decompensated heart failure, and do not resuscitate or intubate patient where there are orders for DNA or DNR. So in a nutshell, what exactly an HFNO does is it humidifies the air so that the congestion and hypersecretion is decreased. It helps in the work of breathing by increasing the flow, and it treats hypoxia. So how does it look? It has got a device where there is a generator inside. This is the main machine. Then there are specific circuits and interfaces, and there is a display screen where you get different parameters. And what is more important is this high flow meter. The flow meters which we routinely use, you can't deliver an oxygen more than 15 liters, but here you can deliver up to 60 liters, and this is a very important device in this HFNO. So there are various interfaces. One is a nasal cannula, the other is a one which you can use it for a tracheostomy tube, and even you get interfaces where you can connect it to a mask. So these are different devices, and they come in different and you can choose this depending on the patient's nostrils. So this is a small animation of how exactly works. Okay, this is a device patented Fisher and Paykel. This is where the oxygen is connected. Here the machine draws in room air and the oxygen, which gets blended in this blender. And this is what decides on the FiO2. This blended air comes into this heated humidifying system, where the water is heated, which generates small water vapors, and the inspired the gas, the air is heated and humidified, and this circuit is got a wired system which is which is concealed. There is nothing open in it. All the wires are concealed, and the condensation doesn't happen because of the heated tubings. And this is how you set a HFNO. Once you switch on, it shows when the machine was last disinfected. Then you have to wait till the machine calibrates to its initial booting phase. These are the three parameters. One is a temperature, second is the flow, and third is the FiO2. You should wait till the machine calibrates and gives an beep telling that the machine is ready. You get a beep after some time. So always it is better to keep things before, especially during intubation. Then you have to set the temperature by pressing these two keys simultaneously. The lock it gets unlocked, and you can set a temperature. Usually we set a temperature between either 31 or 34 degrees centigrade, which is more than enough. 37 degrees is needed if you are using it for a tracheostomy. Then the next thing is you set the flows. Again, you press these two buttons simultaneously, and once it is locked, you can set an flow. And once you set a flow, then the next thing is the FiO2, setting of a FiO2. So the FiO2 has to be set in a flow meter, which is shown here. You keep on increasing. How you increase the flow of oxygen, the FiO2 on the screen keeps on changing. So you have to keep a particular FiO2 and check whether the patient's saturation is improving. Or after 5-10 minutes, again you can keep on increasing. Now the basic thing of an HFNO machine is it blends the oxygen which you are giving and the to make actually things easy. What I did was I had the machine at 50 liters per minute. So out of 50 liters of flow, 43 liters is given by the oxygen, the rest of the 7 is air. So the calculate 43 that will be 86%. See, the FiO2 displayed here is 86%. Of explanation, I had set it at 50 liters per minute. So between use of the machine, between two patients, it has to be disinfected. So normally disinfection is done by moist heat, low temperature sterilization process. But because these are electronic equipments, they don't tolerate moisture. So what Airvo 2 is, it's got a special validated form of disinfection called as a thermal disinfection process, which has been approved by FDA and AAMI guideline. The microbacteria which are found in the outlet of the HFNO machine, the microbacteria which were the number of microbacteria were accepted standard with this type of disinfection, that is thermal disinfection. So what are the practical recommendations for the use of HFNO? You choose a nasal prong, doesn't totally occlude the nostril, which may be very uncomfortable for the patient, and it may also cause trauma. Start the patient at 30 to per minute of flow and increase to meet the patient's set the temperatures between 31 either 31 or 34 degrees. You increase the FiO2 until you get a satisfactory SaO2. Increase the delivered flow until reduction in respiratory rate and stable SaO2 is achieved. So you have to keep an eye on the respiratory rate of the patient once you initiate an HFN. Most continuous monitoring of heart rate and saturations are so, when a patient is wheeled into an ICU, you are starting an HFNO depends on the general condition of the patient. Patient is unconscious or gasping for breath, hypoxic. I think they are not ideal candidates for an HFNO. Awake cooperative patient is when you are using an HFNO. So, and once you initiate HFNO, is the patient should be put in only where there is monitored environment. That's why I put a bold word of monitor. The patient has to be continuously monitored, and you have to see the patient continuously how he is responding to your therapy. It's not the only criteria. So you can put the patient on NIV and HFNO, and I have seen there have been studies where you both NIV and HFNO simultaneously. Patient who needs both, I think it's a clear-cut indication for intubation. Should never delay intubation because you got gadgets like HFNO. Awake proning is very easy with patients who are on HFNO. Then whenever the patient is on HFNO, your ventilator should be always ready because you may have to intubate the patient anytime. And post-extubation, especially RDS, there is a big role in HFNO. So how do you know whether your HFNO which you are initiated works? So initially in the first 5 to 15 minutes, the respiratory rate comes down, the oxygenation of the patient improves, dyspnea also, the work of breathing comes down in about 30 minutes. The supraclavicular retraction which you are seeing also comes down, and the thoracoabdominal asynchrony starts decreasing. There will be more of a synchronized breathing. So respiratory rate reduction appears to be a very good predictor for a therapy success. My talk will not be complete if I don't talk about a Florali trial, which was done way back in 2015. It was a multicentric trial where they used a nasal hyphae and they compared it with the non-rebreathing mask and NIV as a primary treatment pre-intubation. And they found that the nasal high flow significantly reduced the ICU mortality. It significantly reduced the need for intubation in more acute patients, significantly increased the number of ventilator-free days, and it significantly reduced intensity of respiratory discomfort and dyspnea. So definitely it helped. If you can see the graph here, the 90-day mortality was very significant between an NIV and HFNO, and similarly, the reduced intubation rates as compared to NIV and HFNO is quite significant. So coming to the second part of my presentation, what is the role of HFN and COVID-19? This is the slide which you've been seeing for the past 4-5 months. What I am interested to show you is when the patient comes to the hospital. So he comes to the hospital somewhere between the 3rd and the 5th day, and he gets into the ICU somewhere in the 6th day, and this is where the intensivist works start, and we have to be more careful. So there are patients who about 5 to 12% of the patient gets intubated. 6% of the people who come to the hospital are on prolonged ventilation, and 0 to 5% of the patient go on tracheostomy. Seeing on the above course, the non-survivors, if at all they treatment like ECMO, die with an average of 21 days. And the survivors, they stay in the ICU for a longer time. This is what this slide depicts. And Gattinoni, in his initial on COVID pneumonia, published that there are 2 types of lung types in COVID-19, the A phenotype and the H phenotype. The L phenotype has got a low elastance, whereas a high compliance. So here the compliance and the amount of gas in the lungs are near. So here you will not have to follow that usual ARDSNet protocol. but you have to take in the compliance is high than low in this phenotype. It is in the earlier part of the disease. The low ventilation and the hypoxemia is due to the perfusion regulation loss and hypoxic valve. On the other H phenotype, it is very high elastance and very high. You need to do ability because there is a lot of edema in the lungs, and the lung weight is very, and the right to left shunt is more. So as the disease progresses, it progresses from the L to H phenotype. There was another study which came by 1, 2, and 3, almost the same, but come with an intermediate category. In phenotype 1, the CT scan shows multiple, possibly over-perfused ground glass opacities, and the compliance again here is normal. Where the phenotype 3, the patchy like pattern can be seen on the CTs. There will be alveolar edema compliance, and here the RP protocol has to be followed. So this is the flow of oxygen therapy in a COVID patient, starting from nasal cannula mask, then with the reservoir, venturi, NIV, invasive, and finally the ECMO. Surviving Subsist campaign has come up with guidelines for the management of critically ill adult patients. When a COVID-19 patient with hypoxia comes, you have to examine and see whether there is for endotracheal intubation. If there is an intubation, straight away go for it. Don't delay. Expert to handle the patient to be intubated. All the PPEs and masks to be worn by the person who is going to intubate the patient, and minimum in the room. In case the patient is fit for an HFNO, tolerating oxygen, then to be monitored closely to see whether he worsens, whether the target SpO2 is reached, that has to be observed, and appropriate infection control precautions has to be taken. So if he is okay, then you can consider HFNO. If he is not tolerating it, then you go back to intubating the patient. A small trial of NIV can be given for such patients. But most important is, by using HFNO, please don't delay intubation because the mortality is very, very high. So next, what we come to is the proning of the patient or repositioning of the patient. Initially, it was proning, but now what is said is it is what you call as a CARP, COVID Awake Repositioning Protocol. The patient is made to sleep with the in a prone position, which is more comfortable with a device like HFNO. So once they come, they are in a prone position, they can try it for half an hour, 30 to about 120 minutes. Then they move to right lateral position. Then they sit up for 60 to 90 degrees, and this they keep on changing position so that the different parts of the lung starts recruited. Even the fifth position is come, that is the Trendelenburg position, but is a little difficult because I think you need high-end ICU beds to try this position. But COVID, this proning and repositioning has definitely helped in improving the oxygenation. How actually changing of position helps? When the patient is sleeping supine, it definitely reduce pulmonary function. That is because the alveoli are overinflated and the dorsal alveoli are atelectated, and this cannula is there. There is ventilation perfusion mismatch. And how does the repositioning help? It makes ventilation more. It helps in redistribution of the blood flow, improving the ventilation perfusion matching, and thereby the oxygenation. There will be reduced and reduced shunt. The lung compression is because there will be offloading of the posterior zones of the lung, because once the patient gets the weight of the heart falls down, you will have what you see is an better inflation of the posterior portion of the lungs. So the lung segments get recruited, and more important is the lung clearance. You can even in our intubated patients, when the patient is put prone, you get lot of patients in the through the endotracheal tube. So this positioning helps. And there have been many studies showing the benefit. One by Cyril Despres, where at least uh, 3 out of 6 patients intubation could be avoided. Uh, Here you can see is initially the patient was started with a conventional oxygen therapy, then they moved to an HFNO, so the intubation avoided. So definitely HFNO has got a role in not going to the next stage of that is intubation. So another thing being discussed is aerosol generation. Uh, there have been changes in the. There are many papers coming out about 3-4 months back. They told that HFNO to be totally not used. But the newer studies have come where it's shown that if the patient who is on HFNO wears a mask, definitely the aerosol generation is much less, as shown in this picture. So if the patient is not on therapy but without mask, still what you can see is the aerosols can go 31% of the people, the aerosols can go up to more than 1 meter. And what you can see here is even you are using a high flow of 40 liters with mask, only 15% of the aerosols can reach up to 1 meter. And if there is no therapy, it will be really less. So whenever you use devices like nasal cannula or a high flow nasal cannula, using of the mask will definitely increase in the spread of aerosols. And the same thing in a different slide. This has different devices, and what you can see is the highest aerosol generation happens with an NIV, and HFNO actually is the second last if it is used properly. So the distance an aerosol can travel is about on an average 4.8 to 17 centimeters with an HFNO. But going by the studies, you can't be casual. You have to be wearing your standard PPEs when you're walking inside the ICU and doing aerosol generation procedures. So this is one thing which I want to stress. HFNO is not the ultimate for treating hypoxia in any of these COVID patients. So you should keep an continuous monitoring, and you have to predict the HFNC failure. One of the way you can do is by seeing the ROX index. The ROX index is nothing but it is a ratio of SpO2 by FiO2, which is divided by respiratory rate. So if this can be serially seen at 2 hours, 6 hours, and 12 hours, in this study they did that, and they saw to it that if the ROX index is about 2.85, 3.47, or less than this in 2, 6, 12 hours, this is a candidate who is probably needs intubation, and the positive predictive values are also very high regarding this. To show how an ROX index is calculated. So example, at 6 hours the patient is on a SpO2 of 88 and an FiO2 of and breathing 28, so his ROX index is 2.48. And if you see this table at 6 hours, if it is less than 3.47, then initiate and go for intubation. Because it is 4.48, you can continue patient on HFNC, but it has got its own pitfall. There are cases where the patient breathing less than 30 times, but his work of breathing is high. If you don't look into that his work of breathing, you may again fail in delaying the intubation. So the clinical things matter. So that come up with a work of breathing scale and monitoring of intubation in COVID-19 patients. So 4 parameters which you have to look at, that is the respiratory rate, which has to be counted. Is less than 20, you score, the score is 1, and if it is more than 30, the score is 4. Then you observe flaring. When if there is a flaring, score it as 1. If it is sternocleidomastoid, if the sternocleidomastoid is, then you score 1, and abdominal muscle is used again. So straight away, if the patient respiratory rate is 4, more than 30, then the points will be 4, and definitely this patient will nasal flaring, and this is a patient whom you have to monitor, and he may need intubation anytime. So this is what it said. If the work of breathing scale is less than or equal to 4, you can continue the present therapy of HFNC. If it starts crossing above 4, then the work of breathing is high and he needs intubation. So next thing is how do you wean a patient from HFNO? First, you keep on decreasing the FiO2 by 5 to 10% and see whether the patient is saturating above 90-92%. If the patient continues saturating better, you keep on increasing to 0.4 or 0.5 of FiO2. Once the stabilize and saturating well on a FiO2 of 0.4 or 0.5, then you start decreasing the flow progressively by 5 liters till you achieve a flow of the patient is comfortable and saturating. The time you can stop start standard oxygen therapy. So in a nutshell, what I suggest is HFNO is a very good mode of therapy for hypoxemia, but continuous is mandatory. Thank you. I am done with my presentation.
Yes. Thank you. Can you hear me? Yeah.
Yeah, now we can hear you.
Yeah. Thank you for a lovely detailed presentation, Guru. We'll just have a quick sort of a panel discussion on a few important aspects. I think Dr. Prasad has touched on most of the important issues. So we'll just sort of highlight some practical.
Neil, we can't hear you. I think there is some.
Take it forward. Dr. Ravi, just if you could highlight some, if you could just outline a couple of points.
Sure.
Can you hear me now? Yeah, can you hear me now?
Yeah, you're back, Sunil. You're back, Sunil.
Yeah. You can hear me?
Yeah,
we can hear you.
Yeah. So Ravi, if you could just highlight the 4 or 5 physiological principles on how HFNO is helpful. How does it improve the oxygenation in type 1 failure?
Yeah, I think Guru has very nicely outlined the role of HFNO. It's a very unique concept, which basically mixed a combination of physiological factors, the dead space reduction, comfort, above and beyond what was already happening out there. So I think Guru's slide was quite self-explanatory, where he showed that flow is an essential requirement of, so it's an observational science where you require flow. The flow cannot be met by natural mechanisms. If an external mechanism can meet the flow, then of course it makes a big difference. Then came the second aspect of the flow being an additive factor, not only in meeting a physiological requirement, but also reducing dead space. Then the third physiological aspect is the expiratory impedance giving a certain level of PEEP, which takes the flow not only to a requirement level, but also adds that vital and expiratory component, which is so important in lung injury of a certain variety. And then came the comfort aspect. And then, of course, the complicated part of the flow coming with a risk of dehydration, dryness and coolness is taken care of by a technological advancement. So when you put all of that together, then you get all the advantages of meeting a requirement, a comfort level in a way which is unprecedented, because comfort has been a major part of whatever we do. In addition, giving a PEEP component, which has been a little wild card, and we can discuss that on this quantification which has come over there, with ultimate advantage of reducing work of breathing and trying to support the patient while the intrinsic physiology improves in a complex situation such as acute lung injury, which so far was not so applied to an extent as seen in COVID ARDS. So when you put the whole conglomeration together, it is basically something waiting in the curtains for its time to come, and suddenly it has shot on to prime time. And that is why both an understanding of the physiology, the need over there, and ultimately applying it to COVID ARDS, CRDS has been what has been the revolution in ICU care in the last 3 months.
Guru, you already have discussed about what are the sort of indications of HFNO in a setting of COVID. Can you just, in your own in your practical experience, just enumerate a few points of where when you would start considering HFNO, some sort of an indication, and what are your guidelines to say that okay, this is a patient on whom I think HFNO will benefit, and more from a practical consideration. I know that there are a lot of theories. I mean, we have discussed a lot about the theoretical aspects and evidence. But just from a practical perspective, take-home points for the audience on how you, when you consider HFNO for a given patient.
Yeah, first is you see the clinical picture of the patient. How comfortable is a patient with your initial oxygen therapies like nasal cannula or an non-rebreather mask, reservoir. More important is get an ABG done. Get an ABG done and see for the PF ratios. Serial ABG will definitely give you a picture of an improving oxygenation in a patient. And if the ideally they say means what is seen is any PF ratio less than 150, which is there for more than 48 hours, the patient needs intubation. But if clinically the patient looks better, you can stay with that. But if the patient's oxygenation is not good, if the PF ratio is really low down, then I would definitely think of going from the low variable flows to HFNO. More important is the work of breathing. If the patient is breathing hard, I think there is no, you have to give an high flow support to the patient.
Dr. Guru, what is the practical application of the ROX index? Do you use it routinely in your clinical practice, and do you find it useful, or on the ground realities, is it really very useful for you to make decisions on the patient? Dr. Guru?
Okay, it's for me. Okay, yeah. I thought it's for Ravi. Yeah. Basically, it's an index which can be used on a bedside. Isn't it? You get a saturation on the monitor. So you get a, what FI to the patient is getting in front of a patient. Calculate the SF ratio and look at the respiratory rate. Then you can calculate on the bedside. This is a bedside index which can be calculated. Doesn't need high rocket science for calculation. But as I said, that the pitfall has to be looked at. If the the patient's is very high, but his respiratory rate is less, you get a better ROX index. But that should prevent you from escalating the treatment.
Yeah. Dr. Ravi, go on, please. You wanted to add a point. Please go on.
Let's make it more interesting and more provocative. ROX index reminds you of rapid shallow breathing index and so many other indices which have come into critical care.
Yes.
Indices which come into critical care first come out, get validated, need to validate the particular condition, then people need to understand it. It needs to make sense in the practice, and then they will follow it. The ROX index was not put out for COVID ARDS at all. It was there before. Now, what is your take on it? Do you think indices like this are actually useful in the bedside, or do you think
honestly, honestly, not very much. I think for an experienced clinician being at the bedside and the experience that we develop with HFNC and its process, I think is a much better tool. Definitely, but I suppose for a beginner or a novice who has just started to use HFNO, it may be still some sort of a rough guide. But I fully agree with you, Ravi, that that's why I posed that question. That despite of the fact that we have spoken a lot about ROX index, I think there are certain limitations of various indices, as you have rightly said. And in our own experience, I think with the different indices which we have used for mechanical ventilation or other sort of weaning forms, it is not really of that much help once a certain level of experience reached. But perhaps it's a good starting point for a beginner or something of that sort. So yeah, go on, please.
So it's also raised an interesting question that A, do we implement that science to your bedside? Secondly, it's simple. That's a good part of it, that all indices are simple. If they're like some complex dead space formula, it's never going to get implemented. But the second problem is, if you have ROX not following the book, do you go to NIV? Do you go to ventilation? How do you factor the patient's look in? What is the perspective? So that I think so many complex issues have come up. So lots of the interesting science waiting over there, I think minimally applied and maximally challenged at this point.
Very true, very true. Fully agreed. So one of the questions posed by one of the participants is that this will be probably for Ravi. So many times when you start HFNC with a certain flow and an FiO2, you find that the patient saturation actually dips and they seem to be saturating better on non-rebreather mask oxygen. So do you want to take that practical question, Ravi?
Yes, it's a very interesting observation. And I think it's all a question of the respiratory rate. I mean, clearly that whatever Guru showed in a very nice fashion, the FiO2 titration, which is mentioned, it's not perfect over there. It's not that you're going to exactly get that entrainment. So first of all, it depends on your oxygen supply. Is your oxygen supply really as wonderful that it can keep ramping up to maintain that FiO2 number? Secondly, is that blended number which is coming in actually true, perfect when it comes to the patient when he's breathing at a high respiratory rate? So obviously a non-rebreather, which is entraining oxygen, has the potential of giving a higher FiO2 if the non-rebreathing component is good, while a tachypnic patient, especially with factors such as blending, mouth open would be a major part of the whole thing, may not necessarily fit into the paradigm of I'm giving this number, but I'm not giving this saturation. So it's a very good observation. I think it follows the fact that other variable factors also contribute to the ultimate alveolar FiO2, which may not be same as the delivered FiO2, and that disconnect is somehow bridged better by a non-rebreather than a HFNC. Having said that, it's only one parameter. You have to understand that there is also a PEEP element and all the other 5-6 factors which were pointed out, which is going to add to the HFNC's value addition. So between the two, one has to take a decision. But as a sine qua non, low saturation, which is because of these variable factors, will obviously prompt the need for either go back or go front to the next level of intervention.
So obviously every intervention has a certain effect or adverse effect, if I may say. Dr. Guru, can you just, for the benefit of the audience, explain to the audience what are the practical things that we need to look as complications which are potentially possible with HFNC? So what do you think, I mean, if you could just list out and say how do we look for or how do we monitor a patient for these potential complications?
The number one complication.
Dr. Guru, if you could also focus primarily on the barotrauma part of it.
If I had to tell, I'll complete the first part because HFNO is giving a false sort of confidence that HFNO is the ultimate treatment in COVID or ARDS. That people should get away, and definitely it is just another mode of giving oxygen. So if HFNO is not tolerated, you have to go for an early intubation because if you keep on delaying, the mortality rates are very, very high. As far as barotrauma, again, it is the flow, high flows which are getting into the airways. So what we have seen, I have not observed much of barotrauma here with HFNO, but I am getting few patients who were on NIV for pretty long time, and I could in fact there was a patient who was trying to do an echo on a patient who was on HFNC for a long time but intubated in our center. I couldn't find a cardiac window. I couldn't understand what was happening when I am trying to do echo. Then finally we realized that the patient had developed pneumomediastinum, which is purely a barotrauma. Barotrauma with HFNC I have not seen much. I think Dr. Ravi can highlight on it.
Dr. Ravi, would you want to?
Yeah, so barotrauma has been a nightmare of COVID ARDS. Unusual large barotrauma, unpredictable barotrauma, which when does it come, what stage does it come, and what are we doing, and so on. So if I could take a minute or two, Sunil, we'll talk about barotrauma. First of all, is it intrinsic to COVID ARDS or is it because of the therapies we use? That has been a fundamental issue. Clearly, COVID ARDS has come with barotrauma without positive pressure as well as with positive pressure. Clearly, positive pressure seems to be increasing the barotrauma. And then the question comes down with, is it more with HFNC, is it more with NIV, or is it more with ventilator? Intuitively, one would think it is more with either NIV or with ventilator, because that is where those two entities of H and L compliance, which I doubt, Sunil, to be very frank with you, after working in these places for a while, And the second part of it is the PCLE component. Another doubtful thing, basically. Two major things of PCLE and the compliances have been put out there, which seems to be highly fancy literature with difficult application to the bedside. In such a situation, why is there more barotrauma? First of all, something peculiar about COVID ARDS. Secondly, we are using a lot of steroids in ARDS. So that is another problem, because in case you get a small rent also, I think the healing is a problem over there. Thirdly, if you add another immunosuppressive agents like tocilizumab and all, that also creates a problem. The last part of it is the fact that we are probably doing more of non-invasive strategies than we ever did in ARDS. So HFNC, NIV and all are used much more. Lastly, what I feel as a practical observation is what's called the pressure fluctuation, especially in NIV when you take it off to give them food and so on and so forth, and then you put it back again, there is a pressure fluctuation which happens. So multitude of factors. Lastly, the most important one would have been if we could have structurally studied them, done CT scan, see the impact and so on. But we're unable to do that because of these sick patients. But certainly peculiar to ARDS is the issue. Positive pressure seems to be worsening it. In order, it's either ventilator and HIV, which I'm not sure, which is more followed by HFNC. Even without positive pressure, we are getting barotrauma. Barotrauma seems to be taking the prognosis adversely. And I think it's a major concern with whatever we use. Having said that, strategies is like maybe adding to what Guru's presentation was. Use it for the shortest amount of time and get out as fast as you can. If it comes to ventilation strategies, if it comes to steroid strategies and so on and so forth, that seems to be the only thing on the ground we have at this point. And Sunil, I would love you to add to this discussion. It's a very provocative and interesting thought.
Yeah, so I think as you rightly said, we have probably used non-invasive strategies a lot in this form of ARDS, which we have never done in the past. And I think it also adds to the thing that, there was a lot of talk about not using HFNC initially because of the risk of healthcare worker being exposed, etc., etc. Now, swung to the other side that you start using more of HFNC. So I think I largely agree with you that we are a lot on the gray zone, very little data available for that. And now, having said that, Ravi, I would like to extend the discussion to what are your thoughts and suggestions for the risks of HFNC or NIV to the healthcare worker. So as you know, there was a lot of talk in the early part of the pandemic that we try not to use HFNC, but we know today that there is some sort of data to say that HFNC is beneficial. We know that from our past experience in type 1 failure, mild moderate ARDS, it is still useful to have HFNC and decreases ventilator free days and such other things. So what is your advice to the healthcare worker in two aspects? Number one, the reluctance to use HFNC should be there or should not be there. And secondly, if at all we are going to use, what are the risks and how do we circumvent it? Dr. Ravi.
So Sunil always brings up very interesting questions. So the question, I think COVID ARDS has been a fundamental split the lines in the middle where it's either outcome to patient to outcome to provider. So if you look at the first part of the COVID pandemic where it hits China, America and the UK, it was risk to provider. So they came out with all the literature that high aerosol generation, so AGP, a very fancy word, they came out aerosol generating procedure. And they said anything which blows anything out. So that's HFNC, NIV, whatever we do, nebulization, suctioning, bronchoscopy, all of them, endoscopy are going to cause aerosols, stop it. So everybody got intubated. And then those weird guidelines were there, Sunil and Guru, if you remember, where they said they should not even intubate beyond the point. Elderly intubations are avoided, and largely came from the New York data where 97% of people above the age of 70, I think 75 died when they went on mechanical ventilator. So initial part of COVID ARDS, Western world, aerosol generating, protect the healthcare worker, intubate everybody, large amount of people died. Shift a little later, it takes a month or two, data comes out, it's not as bad, in vitro data is given out there. In vitro data had two types of followers. A, I get convinced for patient care. B, I still think I'm the most important person in this cosmic universe. And still the adoption of these things were not followed. C, come the pandemic to India, and I think first of all, we don't have so many ventilators. On top of that, we can't run so many ventilators. And thirdly, of course, let's face it, scientific knowledge said that it's possible. Lastly, it also coincides with the protection, that if you put in enough engineering controls, you can probably protect yourself from these aerosols a lot. So combined with the delayed pandemic hitting us, combined with the need for non-invasive strategies, combined with the understand that mechanical ventilation people die, healthcare providers being more savvy, PPE getting better, and engineering controls getting better, came the fact that non-invasive strategies are okay to do. And I think, Sunil and Guru, that has been the single major thing which has saved a multitude of Indians. It is the recovery part of India. The recovery trials, recovery for India has been the use of this non-invasive strategies. So
True,
now to
true.
put the science into perspective, yes, it has been talked about, but no, there's enough proof to show that the aerosol is not that bad. Mitigation of strategies by putting a mask on the HFNC can reduce that. Certainly, good engineering controls should be a part of it. Air exchanges and all those things talked about. Certainly, we don't have negative pressure rooms, but air exchanges of a certain nature, more than 12 desirable, more than 6, of course, extremely important. And lastly, good PP by the providers and the judicious strategy, whom you put on, how long you put on, and how you come out. So I think that has been a game changer. Lastly, the flow component. Initially, they said keep the flow low. Don't use more than 30, 40 HFNC and so on. I think that also got thrown out of the window, and a recent lovely ACCP paper by Rauf and all also said you can use the usual stuff. Go with the 50, 60 liters a minute, because ultimately now there's a balance of strategy and outcome for the patient, the provider, and the system. So I think it's a long answer to a question, but a lot of points had to be summarized.
And I think well covered. In fact, very practical, I should say, Ravi. Ravi, in the same context, what is your take on using a combined strategy of HFNC and NIV? I mean, there is some data about using this combination. So, what is your take on that? And if so, what are the guidelines you would want, or simple guidelines you would want to give the audience about it?
Yeah, so interesting. Another practice parameter which has come way overridden any science which can come, because clearly it's difficult to develop science. Again, the ACCP paper which came out recently versus what is done in practice. So here it's very clear that A, as an escalation strategy or a de-escalation strategy. As escalation strategy, if you're putting on HFNC and it's not doing the job and you switch to NIV, then it doesn't make sense that in the breaks you have to give an NIV, you will use HFNC as a bridge over there in a certain ratio, which is determined by and large by the provider. That is one way of looking at it. The second way of looking at it is when you are, taking patients off, especially post-extubation, as has been talked about, the alternate HFNC and NIV. Advantage of the strategy is, of course, HFNC, wherever it comes, it's going to allow, it's more comfortable, you can eat with it and so on and so forth. The disadvantage of HFNC, which is bridged by NIV, is the fact that HFNC is a volume control strategy. And as Guru pointed out, with that average ballpark number of 1 PEEP for 10 liters, you can get only 6 of PEEP average at the most. So then you have NIV, which is a pressure strategy, which has all its advantages of, opening up the alveoli. I'm not going to get into that, but pressure strategy may be advantageous over a volume strategy. So it is a bridge between the patient who cannot survive on HFNC and needs a ventilator. Can that bridge be done by a combination of these two? And in the reverse, when they're coming off ventilator, can this be used as a bridge? Theory, the principles to be think about for practically is that my patient's not doing well on HFNC, and before ventilator, should I use a combination? That is the main thing. And while coming off, also the similar analogies are there, so that we have a combination of these two strategies. Disadvantage, too many machines. One patient consuming 2 machines is a major problem in India. So that resource is an issue also. 2, technical expertise. It's not easy to keep switching machines and so on and so forth. Thirdly, patient compliance on that. Suddenly you're giving one versus the other. So they will notice a perceptive difference in both machines. And that has to be something which requires more effort at the bedside. 4, science. There is no science. 5, guideline. ACCP has put out a guideline also saying you can do this. Of course, there is no data validation for that, no ROX index, and no such proof for us at this point. But indeed, practically utilized. And Sunil, I'll throw the ball back in your court. Your take on this.
Yeah. So I think, as you rightly said, the science for this is very thin. For some strange reason, in fact, many a time you find that these patients, some of them don't tolerate HFNC and they are better off on NIV. and some of them are better off, tolerating neither of them and end up, more comfortable on a non-rebreather. But one of the things, I think if there is a small element of what you call as a resistive component or an airway resistance, I think the strategy of using NIV may be useful in some of them. They're comfortable that way. Let me put it like that. So I think that is one thing I would add on to what you have already said. Otherwise, I think you have covered most of it. And I think we need more data to say that this dual strategy works. And that's what it is. Okay. So what about, I think this will be again to Ravi, being coming from a pulmonary critical care background. What about COVID bronchoscopy? Is there a role for HFNC, or if so, how do you suggest we use it, Ravi?
So the first thing is bronchoscopy is like one of those rare entities, basically hardly done. But if it has to be done, which we have also had an issue with, and there's been tons of guidelines. I mean, to just sidetrack a little, COVID is full of guidelines on what to do in every procedure possible, and that probably has contributed to the 70K plus papers on COVID. So first of all, before we did COVID bronchoscopy, we used to use HFNC for regular bronchoscopy in fragile patients. So again, it's a bridge, I think, where you anticipate that your regular strategies will lead to desaturation / hypercapnia, and will take a procedure to intubation, which is really, a problem. You use a bridge strategy, and we used to use HFNC out there, start HFNC. The only problem was that if you have to open, we put a mouth guard out there, it's a little challenging. So you have to increase the flows, do your bronchoscopy, and get out as fast as you can with a whole bunch of instructions for that. In COVID times also, it has been a challenge to think about it. It was mentioned, but on the other hand, a lot of COVID guidelines come with the understanding that the more sedated the patient, the less they're coughing, the better it is. So again, talked about as a modality, but not very commonly implemented in COVID bronchoscopy. Having said that, regular bronchoscopy is certainly a very good role to play. Last issue, COVID bronchoscopy also comes with the understanding that to be very, very clear on why you're doing it, what is the indication. Most of COVID bronchoscopies which will happen now are happening in intubated patients for indications such as collapse, infiltrates, infections, and so on. And we're even finding fungi now in these airways in the bronchoscopies we have done. So there, of course, there's no role of HFNC. It's by and large the regular intubated bronchoscopy.
Ravi, in case you have to do a bronchoscopy on somebody who is not intubated, say just on HFNC, is there any added protection or prevention or precaution that you would suggest to the healthcare worker? Is there anything additional that you would normally add on to the usual precautionary measure in a COVID patient, I'm saying?
So now anyway, all bronchoscopy, Sunil, like non-COVID work. So Bangalore is going through COVID and non-COVID at the same time. So as non-COVID work is picking up, though we have COVID negativity, all patients are treated like COVID bronchoscopy. So by and large, the highest level of aerosol protection goes in. In steps 1, 2, and 3, engineering controls have to be very good. Like an OT engineering control with at least 16 air exchanges are there. Then comes the PPE of a very high nature, which has to be used, which means and the N95, the visor, the hood, and so on and so forth. And then comes the actual patient characteristics. So in COVID bronchoscopy, as much as possible, the instructions are very deep sedation to the point of paralysis. That will basically prevent any sort of cough, which is going to increase the aerosol in a very pointed way for the operator. So it's coming down to that. So that is why when you use, if at all you think of HFNC, it has to be very deep sedation so as to mitigate the cough reflex. And there, the OptiFlow concept of the HFNC, so as to maintain that apneic ventilation at the same time, not cause CO2 retention, which has been the claim to fame, is significantly useful in trying to maintain. But it's a thin line because you have to get ready to intubate anytime.
Yeah. Lastly, Dr. Guru, when do we stop HFNC? I mean, you could touch upon both weaning and also re-emphasize on the fact that somebody is not getting better. I think you have highlighted it very nicely in your slides. but for the benefit of the audience, I would like you to re-emphasize on certain lines when you can say that, okay, this is it, HFNC, no more HFNC beyond this, you escalate to the next level of support, or for that matter, patient getting better, in your own experience, how do you start weaning the HFNC?
First, I'll talk about escalation of the therapy. So, the patient is under continuous monitoring, and you are continuously seeing his saturations, his respiratory rate, uh, his conscious levels, how is he behaving otherwise just with HFNC, whether he becomes intermittently hypoxic. All those features we have to see, and if he is desaturating even with up to 60 liters, you keep 60 liters flow and 100% of FiO2, and still he is not saturating well. His ABG is not looking good. His PF ratio is less than 100. I think there is no point in waiting for more time. Give him rest. Intubate, paralyze, sedate for a few days, because you have seen the progress. Means you have to have enough time to see all this. Whether you will have a rough means the initial CT scans or X-rays which you have taken. How bad is the lung? Is he going to improve in a short time? They are the criteria where you take to intubate a patient. And weaning looks more simple with these patients. You keep on decreasing the FiO2. The patient, you talk to the patient, you ask him whether he's getting better. If he is feeling better, you stand along the bedside, decrease the FiO2, see his comfort levels. You have to spend a lot of time besides the at the bedside, so that you know that it's working. And weaning of HFNO is always you keep on decreasing the FiO2 by 5 to 10%, wait for hours, see whether it's saturating, then come down between 0.4 to 50 to 50% FiO2. And if he's saturating well, he's doing well. If the patient says he's getting better, then keep on decreasing. When you come up to you decrease the flow by 5 to 10 liters, progress and reach to a flow of about 25 liters, then give a trial on low and flow, and if he keeps continues to maintain on that, then you can wean him totally off HFNO. This is what I think, sir.
Also, Guru, what is your experience and the guideline that you'd want to give people on HFNC and proning? So as we know that awake proning is a new thing which has been done quite extensively with reasonably good success in terms of at least improving oxygenation. So just wanted to know what you would like to tell the audience on the HFNC and its and proning as a combined strategy.
Yeah, that's very important. Actually, though I mentioned it on the lecture, I couldn't tell it in the previous question. You start an HFNC and you see how the patient is saturating, whether he's saturating well or not. If he's not saturating with good flows, then the next thing is ask one staff nurse to stand in front of that patient, see that the patient keeps on changing, repositioning himself. And you have to see the saturation, how much it increases with the right lateral, left lateral position, proning. With all this, there is definitely one position in which the patient definitely does his saturation improves. That we have to keep note of it and ask him to keep on repositioning. So if at all you are thinking of escalating the treatment, before you escalate the treatment, I think you have to see whether the patient is doing well with HFNC with the repositioning, and only if the patient's oxygenation is improving, you insist the patient to continue this maneuvers, so that we can avoid intubation in such patients. Anything to be added, Dr. Ravi?
Ravi, anything to add on from your end?
So it's an interesting question. Let's go. So if we talk about it, Guru, is that what do you think is the value addition in each one of these components? We have prone, awake prone without giving any oxygen, which leads to improvement. We have awake prone with oxygen therapy, awake prone with HFNC, awake prone with NIV, and of course prone ventilation, which is an old friend of ours. Where do you think this stands over there? Because if you look at physiology, the physiology in each is slightly different. In one, without when patients have not been getting beds, you tell them to lie prone at home, their saturation improve with that only. And then they get the bed and we start oxygen and then things pick up and so on and so forth. But positive pressure prone versus naive prone will have a different pathophysiology. Any thoughts on that, Sunil?
Hello?
Yeah. So any
Ravi, I
thoughts on
lost you
that,
in the
Sunil?
middle. Can you repeat the last part? I actually lost you in
The
the middle.
question was, I have some
Yeah.
thoughts on this also, but the question to both of you was the following. When you have, prone, 5 types of prone are there. Prone
Yeah.
without oxygen therapy, prone with oxygen therapy, prone with HFNC, prone with NIV, and ventilatory prone, where there is pathophysiological differences in each one of them. Where do
Correct.
you see the differences in them? So in such a situation, HFNC prone, is it just an extrapolation of our prone in other areas? Is there a big advantage with all the nice pictures which Guru showed and so on and so forth? But already you're using enough of a positive pressure strategy, and same thing for NIV. So where do we stand with these? Practically, we're going to prone everybody. We know that.
Yeah, so I think obviously the basic concept of proning is to ensure that there is better VQ distribution which happens, and of course the theory of the weight of the mediastinum coming down, all that I think is there. It's probably the combination may add on a bit more by if you look at HFNC or NIV or any other positive pressure as a strategy, it's something that also has a role in recruiting the lungs. So it's probably more effective, theoretically at least, it will be more effective to recruit a lung in the prone position, as we know with our experience with positive pressure as well. So I think I would say, I mean, if there are clinical or evidence to support it, probably there's very little to say that. But from a theoretical perspective, I think the recruitment probably is better when we actually use these different positive pressure strategies in the prone position. That's what I would look at it. What's your thought on that, Ravi?
Yeah, that's exactly there. But I think that the differential, it's a very good point, Sunil. But I think that the differential advantage of different strategies varies depending on where you are. So I think there is a little difference out there depending on the advantage you see. And a lot of this knowledge has come from trying to correlate COVID ARDS as seen on CT scan. So in some of those cases where you're fortunate to get a CT scan, and then you basically go into the prone scenario and you see the distribution of infiltrate, and now you're trying to take that actual knowledge to the bedside, is when you actually realize that there is a subset which will get better. The subset is significant to put it as a very simple to apply strategy. But on the other hand, the lateral strategy over there being an extrapolation may or may not work in all of them. And then how much energy should be put into the prone strategy? So to try and implement it. So these are questions which have come up. Not all of them have answers, but it's a point we wanted to bring up. So.
And also, I think we need to understand the practical difficulties of doing awake proning. Many times you find that they are just so uncomfortable in awake proning that it may never be, we may never be able to apply it on the ground as well. But as a sort of stopgap or a halfway measure, the lateral proning, positioning probably is a useful midway strategy, I would say. And also, I think if you look at the distribution, since there's a lot of peripheral distribution, that probably is also one of the reasons why we may see a little more success in improvement in the oxygenation in the lateral position, which doesn't happen in other forms of ARDS. Anything to add on that, Ravi?
Yeah, so it's a very interesting point. It's also the changing pathophysiology. When we see these patients, you talk of proning as a one-time thing. No, things are dynamically changing. You're giving steroids which are going to cause fluid retention. They're tecipning, which is going to cause insensible losses. Very difficult to assess fluid in these patients, by and large, what's going on over there. Secondly, often you look at proning as something which is a 0.5 thing. Like HFNC plus prone is equal to 1.5 HFNC, maybe before NIV is going to come in. NIV plus prone is going to give you an additional advantage before the ventilator comes in. Ventilator plus prone is going to give an additional advantage if you go to the highest level of ECMO and so on. So I think the differential advantage has been something which is very interesting to see. We club everything together, but I think it is, when you look at it as a pure science, each one adds a little component. How much is always uncertain in every patient.
I suppose the addition, we cannot take it as in a mathematical format. I think individualizing it to every patient is very, very important, as you rightly put it, Ravi. And in the same context, Ravi, what do you think about HFNC, NIV, and probably combination or proning, or its combination with proning when there is a scenario where we are faced with the oxygen shortage or something of that? So, do you think it is something which has a significant role? I mean, just extrapolating the discussion that came from the last few minutes.
Right. So I think it is one of the most practical issues which arose recently. The story started, I think, in the north. And I remember our president of ISCCM was telling us suddenly it happened in Haryana, that they basically had a massive shortage of liquid oxygen and they had to bridge it. And then we all realized also, to give a practical experience, when we went up to, we were compelled to use a strong word, to become a COVID center in a very short span of time. And at 60 beds, we realized that we don't have any more oxygen. Suddenly the 1,000 cubic meter and oxygen, and to put it candidly, we had to understand oxygen capacity better than I ever understand before. 25 years in the field, I had never looked at oxygen. 60 beds we had maxed out, and clearly the lovely picture when you have oxygen sucking in with that massive flow meter and you're supplying it to so many patients, then it's going to be a problem. So the oxygen shortage supply, then a month later, we saw that in Bangalore, at least one of our local centers had a problem and they were trying to ship to other centers. And in the last 2 weeks, periodically in the newspapers and in both in bureaucrats and in the private centers, it has been an issue with oxygen supplies ramping up. So it's been a major issue. And then the issue comes up that do we judiciously use it? And guidelines came from the government of Karnataka, how to cut down oxygen use. But clearly none of these guidelines could factor in the fact that HFNC, you save a life, you need a resource. How do you factor then what is the role of the resource? The resource is HFNC, NIV, or ventilator. Let's not talk about ventilator. If we talk HFNC, NIV, which resource is going to consume more oxygen, and how do you use it as a distributional component if you have more patients? Very, very challenging question. Typically, it will come in India only, where we have massive numbers and a shortage of supplies. Having said that, I think urban areas we have managed decently. I'm sure your center, my center. Guru will tell us if he faced any problems where he had
Guru, what's your experience on that?
Being the owner of the hospital, I spent sleepless nights. There are people who take care of my patients, my partners, but I had to make an emergency arrangement to till COVID we were managing with jumbo cylinders, B-type cylinders. But once we started getting a shortage of oxygen, immediately I had to make arrangements for liquid oxygen, which I could do it in 1 month. Then all arrangements were made for liquid oxygen to come. But liquid oxygen started, there was shortage of liquid oxygen. One day the oxygen supplier told that after 5 o'clock, because they only have not received liquid oxygen, so they can't supply it to us. Then I was thinking what to do. I was planning to discharge most of the patients to some other hospital, but just with some local contacts, I could get oxygen from some other supplier and I could manage. Yeah, oxygen has been, I'm telling my staff, just maintain about, don't think of that 94, 95.
So Ravi, in connection with HFNO, there are some people who use the HFNO without the normal, that specialized flow meter. They just have a blender and use the normal wall flow meter. What's your thought on that? I mean, is it a good practice to use, or you feel that it's not going to be of much value add? It's a very practical problem. I'm sure many of us will have faced it in some of the smaller centers. Ravi, what's your take on that?
Yeah, so I think it all depends. You're talking of the flow meter availability, right? At this point, that 60-liter flow meter. Yeah, so that is an interesting issue, and I think in lesser setups. So, I mean, if you go back to HFNO and you follow the textbook picture of 150 to 300 PF ratio, which I think I'll make a blatant statement, all of us are violating. There's less than 150, whatever it may be, we're going to use every gizmo on the ground to before we use the invasive ventilator. So in such a situation, I think it all depends on the severity of the patient. If it's not too bad, you can do any patch-up strategy like this. But if they're really bad, then everything from flow to FiO2. I mean, what are the two components which are actually impacting care? It is a flow and it is FiO2. These two things are really paramount. And if they get compromised in that, and the severity of illness mandates a stringent amount of these two, I don't think it's going to work. I mean, the rest of it, comfort, humidification, is the facilitation mechanism. But the physiological actual thing is going to be dead space, PEEP, and FiO2.
Yeah. Guru, there's a question from one of the participants that nasal congestion and bleeding seems to be a problem when HFNC has been used for some time. What's your suggestion to avoid it or decrease this risk or complication?
I didn't get the question, Sunil.
When we use the HFNC nasal cannula for a very long time, or maybe a few days on a continuous basis, there is a risk of nasal congestion, bleeding, epistaxis. So what we can do to reduce this risk? Is there anything we can do to circumvent it, or it's just a problem that we cannot do much about?
Even I have not found an answer to that. Dr. Ravindra, can you tell anything what we can do? Because I have seen bleeding nose with the HFNOs also.
Nothing you can do. It is basically based on the premise that this is better than other modalities for both dryness and coolness. But there are people who will crust over there. It's a problem out there. Don't forget that the population in India is full of people who have dry nose, allergic rhinitis, viral affliction of the nose also, which is also causes its own problems, and you're running high flows for continuous amounts of time. Strategy is very clear. You can add an additional amount of humidification. So above and beyond the nose spray, we try to use moisturizing saline over there more frequently as a bridge modality. Secondly, interrupting it. A little break out the interruption if you can do. We never talked of HFNC alternating with a non-rebreather also. That is another possibility out there to reduce the flow rates, which will cause some healing. The third is, of course, prohibitive crusting and bleeding is not that common so as to take off the HFNC, but most of these people will find up becoming mouth breathers. They quickly open their mouth and they start breathing through the mouth, which causes dryness above and beyond anything. So current strategies seem to be only to use extra moisturizer, temperature modifications if possible, keeping the flow lower so that it stays okay, trying to give them breaks. But beyond that, in a small percentage, it will be difficult to continue.
Guru, how common are air leaks in patients with HFNC? There's a question from one of the audience that do you see a lot of air leaks in the circuit or probably even around the cannula side? Yeah. If so, how common is it, and what do we do to sort out the problem?
Yeah. One issue is we are using these devices. These are devices, and we are using it for quite a long time. I think they have to be changed after at least if look at but little amount of leak is accepted when you use a nasal cannula, so that there is enough breathing space so that the mucosa is not hurt. So I think frequent changing, you have to look at the tips, whether they have been damaged. Sometimes they get blocked because being in the nose, the material becomes very soft and starts kinking. So there is a chance that even the flow may not reach through one or both. So and the high flow shows a high obstruction alarm. Even one issue what I saw was there is a setting where the same machine can be used for a pediatric setup. So the pediatric setup was on, and the patient, it was showing continuous leaks, and the patient was not getting a proper oxygen. So yeah, I do see leaks, but the answer is probably we have to change it to a newer cannula, and different sizes, medium, large, and all. We can use a proper interface.
Ravi, just going back to the question of bleeding, do you think if the humidification is optimal and the gas saturation 100%, if the saturation goes up to 100% humidity, if the air is gets to 100% humidity, do you think bleeding can be prevented?
Yeah, so that is the claim to fame of the product. The original HFNC. We have other ones coming in the market now, both other companies as well as indigenously manufactured systems also. But Fisher-Paykel's claim to fame for many years is they are the masters of humidification, and their claim is if it's done correctly, done properly, it's not going to happen. The issue is other systems also. If you have for example, your ICU doesn't have sitting in an area where you don't have AC, it's dry all over the place, and so on and so forth. I think wild cards are there. As we say, no patient follows the rules completely. I mean, all patients don't follow the rules completely for all things we put out. I think it's a thing to be talked about, but very uncommon in practical situations.
Sure.
And
So I think go on,
uh,
Guru. Yes, please.
yeah, see, beyond orifice, the air gets humidified, but not around the orifices. There's a contact of the nasal cannula with the skin and mucosa, which is hurting the nose. There, actually, humidification becomes very difficult. Beyond the orifice, upper airway, yes, there will be humidification, but around, I don't know how it's going to humidify.
So I think we are running short of time, and we have tried to address most of the questions which are there in the. We'll wait for a couple of minutes. If there's any more questions, we can probably take it. Otherwise, we could probably come to the close of the session. So, Ravi and Guru, do you want to have any take-home points, important practical take-home points on the do's and don'ts before we call it a day?
Yeah,
Just 3 or 4 points, Guru. Just 3 or 4 points, which will be important dot points of the entire discussion.
HFNC is definitely a mode which is going to help you during in any hypoxic respiratory failure. The second thing is prevent means you can the SFNC can be avoided. Most important, any patient on HFNC needs continuous monitoring, and without continuous monitoring, managing the patient HFNC is very difficult, because and as Dr. Ravi said, we have to use multiple equipments. When ventilator should always be ready by the side of a patient who is being managed on HFNC. If you've got 6 beds, if you've got 3 HFNCs and 3 ventilators, you put 3 patients on ventilator and you take new patients on HFNC, and if they are going to land on a ventilator, then you don't have a ventilator with you. So that resources you should calculate before you admit a patient, because once we admit telling that we have got all facilities, if the patient is not doing on HFNC or doing well on HFNC, and you need a ventilator, but you've got 3 ventilators which have already been on other patients, so that resource you have to calculate before you admit a bad patient. This is what I think we have to be very careful.
Ravi, do you have anything more to add?
Yeah, so to summarize it from the simple to the complex, I think a modality which was touted from the Florali trial was very interesting, made its way into most urban ICUs, but suddenly shot to fame and set the stage with the HFNC pandemic, clearly espoused by the West and then penetrating to us. And it's really, it is a very useful addition to the armamentarium to try and get out patients before the invasive mechanical ventilator, which comes with its own major disadvantage. Certainly understanding the science, which was the aim of such a meeting, implementing it carefully with both the effort, patient care, and at the same time having plan B, as Guru was pointing out, and then figuring out transitions and mixing and mingling with other modalities is, I think, in the name, the key aspects of HFNC, but definitely a very big value addition to the armamentarium of our COVID ARDS. Not only that, in the last thing, it has completely revolutionized the way we think of ARDS. I mean, I remember a year or two ago, major proponents of ARDS have stood and said, no, don't think of NIV, don't think of all these things and so on. But I think here all rules have been broken because of the way this pandemic has been. And certainly HFNC has also made its way to save many lives. Clearly, it is not, nothing is a panacea. You have to know it. You have to watch it carefully. You should know when to call it a day and go into plan B. And all this is part of any modality, which we all have tried to learn today and have added to the overall existing knowledge armamentarium.
Sunil,
There is one last question, one practical question. Riles tube. How do we manage your patient who is on HFNC if he needs a Riles tube? It's open to any of you.
Riles tube and NIV I know, but Riles tube and HFNC I am not sure. Is there an option, Dr. Ravi?
Ravi?
So you can put anything. You can take a tiny finger tube and put it on the side, and jolly well, there's 2 nostrils out there. You can put it in there. Yeah. Having said that, the rice tube itself is a controversy, Sunil and Guru.
True,
There are
agree.
people with NIV who put rice tube into everybody.
Yeah. So I think if somebody needs a rice tube, most likely he will not need HFNC.
Exactly. Why would they put HFNC in the first place?
That's been our practical experience, I suppose, isn't it? Yeah.
Only reason is when we do a bronchoscopy, if you have any reason to do that. Otherwise, this is a mutually not so great combination to think about.
True, agree. Yeah. So I
there
think
is one question.
Yes, Dr. Guru.
Is disinfection mandatory between COVID patients? Actually, the answer is yes, but I don't know how practical it is possible. Because your HFNC, because at least this machine takes about 55 minutes for disinfection. With this Airvo takes almost about 55 minutes for disinfection, but I don't know how practically it works. But we try to disinfect whenever we get an opportunity when the HFNO is free.
So I think the answer to that would be managing your logistics well. As Guru, you have rightly pointed many times in the 1.5 hour meeting that we had. I think though we are in a situation of a pandemic, we need to be surely planning our resources well. Yeah. So thank you, Dr. Guru Prasad and Dr. Ravindra Mehta. It was an honor to be paneling, to be moderating both of you. I think I also thank Fisher and Packle for giving us this opportunity and all the participants for their patient hearing. I'm sure all of us are going through very difficult times, and at the fag end of a long day, to sit for about 90 minutes and listen to thought-provoking discussion, I think hats off to all the participants. Thank you so much, and thank you for the organizers as well. So I think we'll call it a day. Good night, all of you. Thanks, everyone.
Thank you very much.
Thank you, sir. Thank you. Bye-bye.